from the UK, broadcasting around the world. You're listening to the Mic Drop Club, hosted by Douglas Hamandishe. Message received. You do not need to know what you need. Just engage with the podcast feed. Providing weekly insights into cool stuff we've read, saw, did, or heard about what made us say, wow, eureka, damn, nothing is off limits. If it motivates and inspires you to reach your goals, then it shall be discussed. Featuring guest interviews from high performers and people of influence, and weekly awards for the best mic drop moment. This podcast is guaranteed to leave you pumped up for the week ahead. Don't just live life. Make life boom.
Hi everybody, it's Douglas Hamandishe with another episode of the Mic Drop Club. Today, I am super excited to bring to the platform somebody that we've been trying to get on this show for quite a while. To tell the truth, I didn't have the bravery to ask her, but she's so open, so dynamic, and we're going to explore a subject that few health technology, health transformational leaders are prepared to discuss. So today, I want you to sit back and enjoy this conversation as I welcome Francesca Markland, a pioneer in digital healthcare and a passionate advocate for health equity. Francesca's extensive experience in digital health tech, social care, community engagement positions her in a unique category to tackle this controversial topic. So what is it? Well, what if the government overnight decided to close all the hospitals in London, only permitting life-saving operations? To many, this is a very provocative scenario, and it's intended to be so. As we delve into the art of the possible, unbridled, unconstrained by the red tape that is the NHS, right? What could we do? What would be the role of digital transformation? And how would we integrate all the necessary bodies to have some sort of cohesive agenda plan to support communities? So with no further ado,
Atomic
Francesca,
Mic Drop.
Welcome to the Mic Drop Club. How you doing? You all right?
Thank you. Thanks so much. Lovely intro there. And thank you for inviting me on. I appreciate it. And as I'm sure all your listeners and viewers know, you are a larger than life force in this space. So it's my honor and privilege to be here with you. So thank you. And
oh, wow.
And also I love the spirit of this as an idea of the way that, having this conversation. It's very much echoes the conversations that we have when we see each other in person around that kind of just letting the imagination flow. And I think that, thought leadership kind of area, often when we're in the day-to-day grind of life, you don't get the chance to give that as much energy as you might like to. But if we want to move out of that kind of short-termism, which we've been stuck in a cycle of short-termism for a long time, both in funding and strategy and policy at government level, if we want to shift into more of a long-term thinking, then we do need to really have some time dedicated to thinking outside the box and being a bit more creative with and ambitious with what the future could look like. So conversations like this, however crazy we might take it, however far-reaching we might go, it is helpful because it gets the juices flowing and it helps people to start moving having that forward-thinking view. So I think this is a good thing to do.
No, absolutely. And yeah, we've had these conversations every time we've bumped heads. Big up to Convensis. We had a fantastic digital health. What was the show again? Digital health virtual wars. That's it. I should remember. I was hosting. It's just so many of these that come thick and fast. So yeah, the virtual wars one. I think that will be maybe some of the thread that will run through this conversation. And yeah, we were talking about this. What can happen if you're unbridled, if you're unconstrained? And we constantly in digital transformation, we talk about the art of the possible, right? It's one of the slogans, yeah? But rarely do we actually talk about the art of the possible. It's within a box. Think within this box, these constraints. So have an expansive conversation now. What if the government closed all hospitals? only permitting life-saving operations. So, Francesca, given your expertise in digital healthcare and remote monitoring, let's go from the bottom up in terms of digital infrastructure. What do you think would need to be established to support the population?
Well, I think just to take your sort of question in the round at first, the kind of main what if, we had a glimpse, didn't we, into what that looks like with the pandemic, because essentially the hospitals were closed to everything other than life-threatening stuff and COVID patients. And what that gave us was a culture of permissivity, like where we were allowed to kind of take risks, not clinically unsafe risks, I might underline, not those sort of risks, but risks around trying novel technologies because we needed to do something, because we needed to bridge the gap, because we couldn't treat these people in hospitals in the way that we used to. And for remote monitoring, that was, you know, it allowed us the opportunity to kind of go leaps and bounds in terms of having a live national test bed essentially for these new pathways and developing these new pathways at base. So I think one thing it showed us is that the system can be responsive in adapting quickly to new ways of care, new models of care, new ways of working. I think at the same time, it also surfaced some of the resistance and gave us some insight into where those resistances lie. So I think before we even really think about the technical infrastructure, because, yeah, obviously, you know, there's some basic stuff that you're going to need to have reliable connectivity in people's homes that's able to manage the kind of data transfers that you need to do, etc. But before even the data infrastructure, you need to think about the people infrastructure and the culture change that needs to come with it to facilitate a huge shift of the way that we do things, because really that's what we're talking about, is moving away from an institutionalized, paternalistic, reactive model of delivering health care to something very different, where actually the only time you would need or want to be in a hospital environment would be for a life-saving operation, because actually there would be in this lovely future that we're imagining much better places to receive all of the other types of care, including your home, but also other kind of community-based centres of care. And there are, you know, we can touch more on the reasons around why that's preferable. But I think one of the words I just used is an important one to think about, and that's institutions. Like my local hospital, I won't name and shame, but it looks like at first glance like a prison, or one of those kind of very old fashioned asylum buildings that you see in like a Hitchcock movie or something. It doesn't say welcoming place or personalised care. The care actually is great when you go inside, but it speaks to the kind of way that we have run traditionally all of our public institutions in a very sort of institutionalized way. And that doesn't necessarily serve us as well in this modern day and age. And we've got the opportunities because of technology and just because of learning the lessons that we are learning by doing various reviews and all the rest of it, into some of the harms that having an institutionalized mindset can have, some of the actual harms that translate into, you know, unmet need,
absolutely,
to people not receiving the care and treatment they should, etc. So for me, there's something about moving away from that institutionalized model of care, and I think we'll talk maybe more later on around the kind of community-based care aspect.
Yeah.
But there is the digital as an enabler to kind of say, okay, we don't need these big institutional hospitals in the way that we had them. We need hospitals to serve a very specific purpose for very acute procedures, and, you know, where you need that sterile environment, etc. And outside of that, we should be looking at opening up all the avenues.
Okay, guys, everybody ready?
Atomic mic drop.
Francesca, you packed a lot in that in that monologue. You packed a lot in there. So let me try and break down a few concepts and ideas that you are talking about there. You talked about the institutionalization the institution that is the physical hospital structure. And you talk about people, which is fantastic. You know, you're bang on. I totally agree with you. The people come first before any transformation. Having that conversation, and then we can start building. So when we talk about institutionalization from a clinical perspective, all too often we think of it from the patient's viewpoint. Get the patient in, and every day they spend in hospital, they're becoming more and more dependent on the hospital. And that's where paternalism comes in. We don't really empower them to fully recover and demonstrate how they can live independently. You know, everything's done semi-automated for them, as it were. So institutionalization is a big thing. Have you got any views about staff institutionalization in terms of, as you said, COVID was an opportunity for us to reset, and we had permission to play within a bigger playground. I would say a bigger playground. But do you think institutionalization played a role in the mindset of staff as well, in terms of changing the dynamic, changing these services?
Absolutely. And I think that remains one of the challenges. Well, it's always a challenge in any kind of change management project, I think, is routine and ways of working that become embedded. You know, people react differently to change. Not everybody wants to embrace change. And the people that do want to embrace change often really want to run with it. And then you kind of get a tension there rubbing up between those two. So you really need the people that are wanting to pioneer and champion the change to not, as is often the case, and, you know, I'm sure I've also been guilty of this, to not feel like the people who are maybe a little bit cynical or not kind of adopting this new way of working that you're asking them to do are you know, Luddites holding you back kind of thing. But to use empathy and understand why are they feeling like that, and to recognize that there's a certain amount of comfort that comes with familiarity, stability. You know, these are things that help people to feel like they know what they're doing and they're comfortable doing it. And the way that you ask people to change is important. If you're perceived as imposing change upon people, if you do it without consultation, if you do it without explaining the benefits, all of that kind of stuff comes into how well you can land a large change programs, such as moving into a virtual care from a kind of traditional inpatient or institutional based care. So and then similarly for those who are more cynically minded, there's an awareness piece and a willingness. You know, we need to cultivate an atmosphere where there's a willingness to engage with awareness pieces. And people are busy, you know, time is pressured. So I think it's incumbent on the leaders to, and I wouldn't use the word mandate. I would say to carve out as part of the, you know, we have training time, etc. that's protected and we're allowed to do. This needs to be incorporated into that, depending on what level and what role and etc. you're playing. But there needs to be a dialogue, and there needs to be
okay, guys, everybody ready?
Awareness and engagement.
Atomic mic drop.
It's a handful of people within teams, whether that's NHS sort of e-bodies or ICBs, or whether we're talking that trust and service provider level. There's a handful of people that are engaged on a regular basis with the kind of digital health world, with industry, who understand what the new bits of tech, you know, what the functionality, capability. So if you've only got a very small handful of people that are aware of all that stuff, and they're not necessarily the people that are designing new services or clinical pathways or even involved necessarily in procurement until somewhere later down the line, maybe, then you're kind of asking people who are not fully equipped with the right tools to make important decisions, investing into decisions that will then be used to evidence whether or not these technologies and these new models of care are effective. And actually, you're not setting yourself up for success unless you give those people the awareness, exposure to give them the tools to make informed decisions. And I don't think that we've had a kind of a strategic enough approach to that. So that makes the change management a bit harder as well.
Oh, absolutely. Absolutely. As you're speaking, I'm frantically writing away because you're like ting, 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 mic drops all over the place. So like, it's all good. I was like thinking a lot about in the post-COVID or living well with COVID as most nations are trying to do. The same actors, should I say, or should I call them transformational pretenders, should I say, that were there before COVID. And I'm giving you a specific example of virtual consultations. We know we've had the technology for decades to do virtual consultations. In fact, it's the integral part of virtual wards. It's the integral part of telehealth, but we've faced a bottleneck for the longest period, typically around IG, less so about technology. In the environment that we find ourselves in, do you think those transformational leaders, those chief executives, don't have to be named, those key people of influence who are part of the blocking brigade have changed, re-educated themselves, adopted new techniques, or after the life-changing moment that COVID was, they returned back to the status quo and we're back to where we were as if COVID never happened?
I think to some extent there is definitely overall. I think we're kind of we tended to revert back, and I don't think that's just us in the NHS. I think that's across the board. I think a lot of people thought we were going to see like a big revolution in terms of the way that we work more broadly, and there's been a little bit of pushback on that, and we kind of find ourselves in a little bit of a hybrid position where there's some voices still champion the kind of work from home as, the 4-day week has been a thing that some people are talking about. And then there's also been a kind of no, get back to the office type of vibe as well. So I think that conflicting, we should go back, no, we should move forward is definitely reflected in our digital health kind of world. I think it was good because we've surfaced a lot of the challenges, especially around things like IG, also around contracting with suppliers. And I know in London, we definitely did a lot of work around work encouraging as well, people to kind of think about relationships with suppliers as that relationships, and to focus on developmental relationships, and to try and sort of exploit the dynamic nature of some of the dynamic purchasing systems that we have as frameworks now. I don't think that we're in a space where we're really exploiting that to its full potential yet. So I think, again, the nature of working in this kind of digital health space is very different from your traditional procurements to, third-party suppliers for services or goods or services, because these are novel technologies that are quite rapidly evolving and being updated. So what you're buying at the beginning of your partnership, if you're going in with that partnership mode, you expect really not to be completely different to 2-3 years down the line, because you're going to work together to kind of develop and build and respond to the different needs that arise and kind of do the innovation piece together. Because really for the innovation piece, you need the technology supplier with the ability to kind of adapt and refine the technology, but you need the clinical team and the patients and the everybody that's involved in delivering a service to kind of feed that information in to create the innovation, because the innovation is about doing things in a different way as well, using the technology, but using it to do things in a different way. That's where the transformation element comes in. So it's one thing to kind of digitally enable traditional, for example, let's take virtual wards as an example. You could have the approach, and both are valid. You could have the approach of, let's use this technology to digitally enable an existing kind of traditional virtual ward pathway, because virtual ward, as in like people being cared for at home, is not a new concept. And that's great. And you're using the tech and, great. But you could also design completely new pathways around the functionality and capability that tech it allows you to now have, so that people who wouldn't have traditionally been viable for a virtual ward, or pathways that weren't conditions or whatever, or managing multi-morbidity in a different kind of way, suddenly now becomes an option. So and then that's what I would say is more innovation, because you're changing the way that you approach management of conditions that before were out of scope to be managed in a non-hospital environment. So to do that,
absolutely,
you need to work with a supplier and with their expertise to kind of develop it in the way that to meet your system needs. Sorry, I know I have a habit of rambling, so let me pause.
No. That was, you actually leaned into the very next question I was going to ask you, which was about obviously we are relying on good partnership relationships with suppliers. We do recognize the value that they offer. Some of the challenges that small suppliers, boutique or niche suppliers, we're talking about use cases that sometimes the large players are not identifying because they may not see a strong marker in terms of ROI, but a small company can see it either through lived experience. They come up with these very innovative solutions that speak to the virtual ward scenario, as we are trying to imagine an environment where there's no physical hospital there. So in terms of the point in time that we find ourselves in, is there room for us to think about the ethicalness of some of the suppliers that get onto these frameworks and reimagine what it means? We've seen what happened with TPP and how it knocked the confidence from marginalized communities in terms of, handing over their data at GP, even though you've got no choice, literally. The average person doesn't have any alternative, but that work in terms of building trust within the patient, the organization relationship has been severed. What can we do ethically to ensure that our suppliers, are fit for purpose moving forward? As you say, it's a partnership, it's an iterative process. So our relationship has got to be a lot tighter and a lot more based in trust.
Yeah. I'm really glad you've brought this up. There's a few points I think to make on this. So I guess I'm much more comfortable with the idea of us developing an approach and appropriate sort of contracting arrangements that allows for a more consortium kind of way of delivering. So being able to contract with multiple suppliers to deliver a service or bits and pieces of a service or whatever, because that lends itself well to keeping a good level of competition in the market, and for small SMEs to kind of have space and a valid space to kind of operate in. Because if you do one niche product and you can't offer an all singing, all dancing thing, then that's still a valid offer if you've got kind of a consortium where you can pick up bits and pieces, that work with that particular pathway that you need. You're not locked in with one supplier to do everything. So I think that's the healthiest approach. Similarly, some of the bigger suppliers will kind of have a more aggressive kind of, we're going to just buy out the smaller suppliers. I'm not of a business background, so it's not really my area to have an opinion on that, but sometimes it can feel a little bit uncomfortable from an ethical perspective. I think we need to have some way of managing sort of exiting contracts when suppliers do things or are discovered to have business practices or whatever that are not in keeping with our values, and that, there must be ways of putting those clauses in. But the real problem comes when and the example you gave, when you've got no alternatives. So the duopoly that we have in primary care, EPRs, is a great example, because there isn't really, you can huff and puff, but what can anybody really do? There is no alternative, and that is a problem in itself, because it's an illusion of choice and competitive marketplace or whatever. It doesn't really mean anything, does it, if you haven't really got a choice? Which is another thing that I think is connected to kind of how we want things to be in the future in terms of how patients feel, and the trust element that you mentioned. So I remember, I'm going to give my age away here. I remember when they came up with the great idea of choose and book And anybody that works in primary care background will remember Choosing Book. It was came with much fanfare. And the kind of the headline for Choosing Book was that you were empowering patients by giving them a choice of where they had, who they saw, what consultant they saw, where they went, which is great on the face of it. But when you actually think about it, what does that really mean? Is that just the illusion of choice? Because unless you are...
Thank you for listening. Don't forget to check out micdropclub.com and get the show notes and useful links. Subscribe to the podcast. Don't just live life. Make life boom.
You can just Google these people and find out what's their star rating or whatever. There were no TripAdvisors for doctors back then. So it was a good idea. And there were other reasons for it around system efficiencies and patient flow. And we'll see, similar iterations in other ways as we've got there's already stuff happening with NHS app around, waiting lists and picking where you want to have your treatments and things like that. Great. The flip side of that, and the bit that we really need to do well to change the ecosystem that we're in, is to give the patients, the people, the public, a genuine way of understanding their condition, the procedure, whatever it is. So patient education, but in a really meaningful way. Not just, and don't get me wrong, there's nothing wrong with the leaflets and the pamphlets kind of stuff that is produced, and the information available online is really helpful. But think about what we could do with the AI tools that we've got around sort of NLP stuff, so that you could actually have personalized AI health buddy type thing who could talk to you, communicate with you in your language. And I don't just mean the language that you speak, as in like English or another language. I mean like in your language. So whatever your kind of cognitive, I'm trying to think of a better word. I can't think of a better word. Whatever however you are, whatever resonates best with you, a very complex piece of information could now be translated and communicated into a way that you can personally understand and digest. And that you could understand better than maybe your consultant would be able to explain to you, because, bedside manner is not always everyone's strong point. So that then makes you as the patient have a completely different relationship with the condition that you have or the procedure that you're having. You can take more ownership, but also it can remove certain fear barriers. And again, brings us back to that idea of moving away from the paternalistic model of care, because with that comes other unwanted kind of emotions like guilt and shame and fear and being, don't want to be told off, don't want to say the wrong thing. And those things prevent people from speaking out and saying when they've got problems or they don't understand. So AI and those types of tools, and sometimes taking the person out of the equation, a physical human, and putting an AI tool in there, can actually have benefits. You can get more honest conversations and questions that someone would maybe be scared to ask otherwise. And, there's all other, I won't go on about the AI benefits. People have spoken at length about that before me, but you see where I'm going with it.
Absolutely. Absolutely.
Do you struggle to achieve your goals or to find your purpose in life? Why waste your time dreaming when you could be fulfilling your biggest, boldest, brightest goals? Tune in to the Mic Drop Club and listen to guest speakers and people of influence as they reveal their secret techniques to help you to get to your dreams and goals and turn them into reality. Tune in to the Mic Drop Club, where the secrets behind achieving extraordinary results are shared weekly with your host, Douglas Hamandishe.
Yeah, it's done something about digital enablement using the most up-to-date, cutting-edge tools. But if I would just wheel back a little bit, in terms of this, trusting the system, trusting the supplier, both from a clinical perspective, as you rightfully point out, from the patient's perspective, that trust has to be solidified and uncompromised. Should never be compromised. So on that note, I just want to big up all the work being done by Aisha, Rahim, Victoria Benton, and Hassan Chowdhury, who started this equity charter. which just talks to that. If we could have something that we could trust, even in the form of a kite mark or something that has real teeth behind it, that can ensure that the data used by these suppliers, these institutions, is going to be used for the benefit of the people that have supplied that data. That will go a long way to then allowing some of these NLPs and all this other, because now we want more, I guess, so that the patient can be treated better and in a more innovative way. You talked about new pathways, and I was so happy. I said, yes, new pathways, new conditions. It's almost as if we have stood still and technology is engulfing us, but we're still saying, actually, you need to make an appointment to see a GP, but actually you're on a depression pathway. But actually, when technology now enables us to capture data literally in a more contextual way. So we should be thinking more out of the box, because what is the data revealing? That then talks to the solution that you need to bring to bear. It would be a shame if we're having this expansive conversation and there's no new pathways, as if we've not evolved. We should have evolved. Technology is evolving with in terms of the way that the silicon chips are being advanced all the time. Moore's law has been debunked a long time ago. We're on exponential growth in terms of our technology, and at the same time, staff feel overwhelmed with the technology. When we try to roll out transformation programs that introduce ways of working to staff who are not ready to take that leap or don't feel confident enough to, or feel de-skilled by the new technology that we're bringing that's constantly iterating. What do you think about the economies of scale, in the sense that as we are imagining our hospitals, there are suppliers now that do not sit on the framework for the NHS that hold health data. And I'm talking about typically your iWatch. These are the consumable grade stuff that are moving at pace and encroaching in that health space, traditional health care type space. How are we going to manage that in our new imagined world?
I'm so glad that you mentioned that, because I remember talking about this a few years ago. I can't remember who I was talking to, but a clinician, and I made the suggestion that we, as the NHS, should be interested in this data, and they were horrified. They were horrified at the idea.
They said horrified.
And I was like, what would you need to be comfortable about that? Like, if it was, CE marked and went through the compliance stuff or whatever, then why not? And again, he was just like, there's no way, there's no world in which we would ever need that amount of like data on a person. And I think for me, that I get it. I get the kind of fear of like, we can't become this society where everyone just like every little thing is monitored and whatever, but we kind of already are. So I feel like rather than just be in denial about it, let's optimize. And also let's make sure that, like you alluded to earlier, that our citizens' data, health data especially, is not being exploited kind of unknowingly or unwittingly. If from a consumer perspective, they're not really thinking about what happens to that data or where it goes and how it's being used by Apple or Samsung or Fitbit or whoever. But we should be thinking about it, and we should be actually thinking about it as our sort of from a public health perspective, not only our data, but also we have to think about, if we ignore that, what sort of regulation or what are we doing around the messaging that's coming through from the apps and the various, it's in a wild west of apps out there. So you've got this device, watch, that takes your, counts your steps and does your whatever. And then you connect to some app that takes that data and then tells you do this or don't do that, or you're really fit and healthy or you're really not. But what do we know about any of that? as the NHS, like nothing. We're not regulating any of that stuff. And if we're not offering a credible alternative using the same data set, because they're already generating that data when you go on your daily steps and all the rest of it, then we can't really argue too much if people then end up on weird and wacky apps that tell them all sorts of nonsense about their data. We've got to have a credible, for the sake of being a player, but it comes back to trust. People want to be able to trust the NHS. They want to have a central place to say this. We know that anything and the NHS app is the obvious contender for that. We know that anything via the NHS app, in that, like, if it was a marketplace scenario, we can trust that, that the public, that would be, I feel, and it would be well received by the public, because the trust issues, and when the trust is broken with the NHS, and it happens often, it still polls as the number one, national treasure. People love that, there is still a lot of good feeling to capitalize on there, in terms of protecting people and giving them something an anchor in the kind of choppy waters of
Sure. No, that's a great segue, because and you are so much more than just a transformational leader, because the way that you are describing the scenario is coming from different vantage points all the time. And that's a rare trait. When I speak to a lot of people within this sphere of transformation, they normally come one direction, or they're thinking more about their own minutiae, their own niche area. But figuring out how all of these are interconnected and dependent on each other to move forward is fantastic. So I just want to give you your flowers regarding that. The second point I want to talk about is we have the ICBs, right? They hold a lot of power now. And I was doing my own research on some of the meetings that take place, because all of that has to be exposed in the public domain. You don't need a Freedom of Information Act to get access to ICB minutes. They don't meet that often. And when technology is moving so fast, and if you start looking at the names of some of these members of the ICB, I don't see a lot of dynamic individuals that are moving at pace. You can have a meeting to discuss something that's hit the optics, and then the next meeting's in 6 months. And if you use the COVID example, we know what happens when you have a deficit in data on 6 months. From a population health perspective, part of the population might lose their life. And we saw that with PPE and people of color not getting access to the right treatments because there was a deficit in data. And by the time people meet up to have these discussions, so what can we do to revamp the ICB, to reshape it so it's fit for purpose in our new imagined world where there's no physical hospital?
Well, in my new imagined world, the ICBs would operate with parity in terms of the organisations that make them up. There would be parity with local authority and some public health and third sector organisations as well, which do make up the wider kind of integrated care systems and do have some seats on some integrated care boards. But in terms of joining up, the part of the purpose of integrated care systems was to bring health and care to work more closely together as well, and to have that alignment, which prior really we only had through a few kind of joint funding programs like Better Care Fund, not many initiatives. And that, I can't speak for outside of London, but that hasn't happened in the way that I had sort of dreamed it might happen when they first announced the idea and the concept of integrated care systems. I think that it means the mechanisms are there, so that's helpful. But yeah, I think integration in every possible meaning of the word is what we need. And that in the ideal world that we're kind of imagining, it would be fully integrated. So systems would be integrated. Do you remember the conference that we were at? I think it was Jen Tompkinson's presentation where she talked about lanyard agnostic approach.
Yeah, I've used that twice. So
I think it's Yes, it would be like that, wouldn't it, really? So that as a patient or even as another member of staff, you wouldn't necessarily know that, see those boundaries between services or know that there'd been a handover of care or a transfer of care as such. But I think even for me, it would be even more ambitious than that. So I think you need to, especially with housing, I think housing is a really important part of the puzzle of the health equity problem that we touched on earlier. But also just if we're going to start making a conscious effort to shift more care into people's homes, then we also need to underpin that with a conscious effort to level up, for want of a better phrase, many people's homes, because a lot of people are having to live in environments that we wouldn't assess as okay to put them on a virtual ward. A lot of the people that are going to go and do assessments or are going to surface poverty and other issues around housing that they won't have an answer to as a health professional. But what they do know is that means that they have to say no.
Okay,
to
guys,
this person
everybody ready?
accessing the service,
Atomic
service.
mic drop.
Mic drop for you. You got a mic drop there. Absolutely. Say that again. Just say what you're saying again in terms of, healthcare professional trying to deliver care to somebody, but the environment is not conducive. Expand on that.
Well, it's the other side of the coin, isn't it? So we're going to invest our money and our energy, and I think we should, in creating these new care pathways that mean people can be cared for at home, so they don't have to go into hospital or into a place to receive care. But whilst doing that, when we go to do the assessments to assess, is this home environment suitable for somebody to receive care? And we are going to find plenty that aren't. And those people would then be denied that care pathway, and they'll have to do an inpatient care pathway or receive care in a different way. So that is widening the health inequality gap because we're not able to give access. It's also putting the healthcare professional in a really uncomfortable and unwelcome position because they are having to deny access to a service, this particular service that's delivered to you at home. And not only that, they haven't got an answer to the problem because they're a healthcare professional. So what can they do about this person's housing? The mold on the walls or the fact that they live in a house of multiple occupation with too many people for it to be considered a safe environment for them to receive care or something like that. These are problems of poverty and of housing laws and landlords not living up to their responsibilities, social landlords or otherwise. These are problems way outside of the NHS sphere. It's not in our gift to fix these things. But we've got, if we work as an integrated care system, then we should be on, first name terms with our local authority colleagues in the housing team. We should be, on first name terms with our colleagues in public health to talk about where there, are issues with air quality and so forth. But on paper, you can probably find some strategy around all of this stuff and saying that's a great idea to join up the dots and do all of that. But in reality and in everyday service planning and delivery, that is not happening. And those are the structures that can enable it to happen if we choose to use them in that way. There's not the funding or the will politically, or there hasn't been, but in our ideal world, there would be.
This is why, Francesca, I'm staying in my imagination. I'm staying in that world where we're allowed to play, right? So in our imagination, young minds run free, right? And we are saying that in the ideal situation, in this imagined state, an ICB board will have the relevant stakeholders at position of parity, because we know for population health, the determinants of health, I have cared for people that said, if you move me and my family out of that mole-infested, rat-infested noise, excessive noise from north, south, east and west, my mom's depression will be lifted. My dad will not drink so much alcohol, and I will not have anxiety and worry about things. So there should be parity. What we consider health now is expanded because now we have data. We've got access to so much more data to say actually what is health as such. As a mental health professional myself, we had this, when I was trained, we say anything from the neck down, that's for, acute medicine, physical health. Anything from the neck up is for mental health. We realize actually this is all one. You need to look at everything. Then obviously the environment comes in, education comes in, employment comes in, access to clean air comes in. So I'm so happy that Medway we're looking at, we've actually got our local plan for consultation. So that's maybe something that we, in our imagination, make sure that there's a local plan in every borough, every community that will address the physical requirements to deliver care in the home. Almost like imagine a place where every room has like a care facility room. Can you imagine that? Like a bungalow type situation where everything's accessible. Why not? I'm sure if you take a look at the costs per head compared to how much it costs to care for somebody when the interventions are coming too late and the outcomes are negligible, if not diminished, it might be more cost effective if those budgets are unified across the whole suite. So look, we're all part of this health ecosystem. What can we do? What can we imagine? What needs to be built? I love that. Wow.
I mean, imagine if the planning process for planning a new development of housing, because we know we need a lot more housing to be built, and I think they're changing some of the restrictions to hopefully see more of that happen. But what if, alongside saying, okay, you have to, because often part of the rules are, if you have to build a new doctor's surgery, or you have to build a new local primary school or whatever, because you're going to bring X amount of people into the town. But what if part of those conversations at planning stage were about, well, what kind of digital infrastructure are you going to provide for the housing? Because we want our housing to be connected, because we want to be able to put health and care interventions in there. And actually, the kind of smart house building, which is, it's not a new, it exists, it's out there. And the idea that you build these homes with the functionality, the capability, or the potential rather, to switch on and kind of add on functionality as somebody ages or their condition changes or they require sort of more interventions, so that you don't move into a house feeling like you're moving into a kind of a medical environment, but you're confident to know that in 10 years' time, should you need to switch on some of those functionality, it's there, and you haven't got to uproot and move into residential care facility or whatever. It's all about keeping people at home, independent, living independently for as long and as happily and as easily and healthily as they can. And again, that's a lot of that's going to be around the education bit and giving people tools and ways of accessing information, and not patient knowledge is patient power, in that kind of sense.
Absolutely.
And often that's been the barrier between patient and clinician, and that kind of issues of trust and relationships. But I just want to touch on as well, I think we have seen a real shift to kind of hear people talk about biopsychosocial models of care, and the idea that you've got it. It's kind of like the next step from that, the personalized care approach, and it's that holistic thing. And I think that's definitely the way that we have to do things. And we need that both in the way that we look at patients, but also our systems. But also as well, there's, again, back to that kind of bigger picture and taking it all in, thinking it's something around mental. So we talk about mental health and mental health crisis and sort of serious mental illness and things like that. And we also talk about anxiety and depression. And we're much better at talking about these things now. But we don't talk so much about mental healthiness or emotional healthiness, and actually things like feelings of self-worth, value, and those kind of feelings can become heightened, or that, especially if you have negative experience, can heighten when you're using health and care services. If you don't feel that you are being valued, or your doctor hasn't explained your condition to you properly, or that kind of thing. So that our emotional well-being and how we feel about ourselves and how we feel that we are perceived by others, all of that is, it has an input to our the care that we receive, but also the care that we give ourselves and how we kind of understand our own conditions and manage things. So there is that kind of, I feel that we're getting into a better space at treating people as real individuals in the way that we deliver care. technology and data specifically, at this point anyway, data is our like the kind of data that we can pick up using the remote monitoring that we've got now, and questionnaires and the rest of it, and like passive monitoring and all of that can tell us an awful lot. And at some point in the future, not too distant future, we'll be able to have that kind of pinpoint individual personalized data at like genome and kind of DNA level for people to really personally map out your kind of care plans and the areas that you need to give attention to prevent ill health in the future. And I'll pause there because you might want to think about it.
No. It was good. I like the way you were flowing with that. So what if homes were built in a modular way that you could bolt on or take off things that you needed to support your well-being? What if children were involved in the local plans for their communities and got them involved in sustainability at earlier stage? You know, what if we taught meta skills to our young people throughout life to embrace dreaming, to embrace feelings, to embrace all the things that we tend to shy away from because it's not quantifiable and deemed as wishy-washy type stuff, but rears its ugly head when you're now depressed, because you need to dig deep when you're in depression to raise yourself up out of that condition. And it's always the unquantifiable stuff that we run away from that you lean into to get yourself out of that situation. So there's a lot about re-education that really needs to be embraced to support a well-being, a country, a city that is well emotionally, psychologically, spiritually even. All the dimensions of self needs to be addressed. And I think with that data, I think we'll be getting to the crux or the nuclei of what makes us who we are on an individual, personalized way, which is going to be a beautiful state of affairs. Because at the moment, you get rudimentary care. Break a leg, we put in the car 6 to 8 weeks. You're on your own. You know, we don't really take a look at all the other things that the finances are going to be impacted on the individual who, particularly if you're a footballer and you're broken your leg. Your mental health is going to be compromised. You might not want to do the same moves on the football pitch because you remember what happened to the break, how you broke your leg in the first place. There's so many factors that, and we haven't even started talking about how will human beings connect to one another in this new and imagined state where there can be, you know, where will they meet? You know, what sort of environments will be used to promote that coupling of human beings, which is also important for people to find value and be valued, is when we connect to each other or something that we're passionate about. So what are your ideas about going to a subject that health rarely talks about? I've been a nurse for 23 years, and there are two subjects we don't talk about in nursing, particularly. We don't talk about it. One is the physicality of relationships. We don't go there. We don't go there. We don't talk about religion. But I can tell you, the vast majority of people I've cared for have had those two things amiss in their lives. Mm-hmm. So we say holistic care, but we said, no, don't go there.
Yeah, no, I think that you're absolutely right. There's always like a holistic, but not this, but we can't talk about. Yeah, the physical, this is an interesting topic just more broadly in the tech kind of space and world, especially when we think about things like the metaverse that's coming and all the rest of it. But yeah, the sense of community, you can have a sense of community that's in a virtual space, in a virtual world. And actually we saw some great work with group video consultation. So for people that were in a diabetes kind of peer network, and they would have like a group chat thing together. And that was really helpful. And it gave a sense of community for them. But you're right. There is a physical, you know, we're human beings and we need physical contact with other human beings. Now, loneliness is a huge, huge, huge problem. A silent killer, for want of a better phrase. It's massive. And loneliness it's more than just, I can have a chat, ring a helpline and have a chat with someone, or which I absolutely encourage people to do if you need to do that at any time. The people that work on those are absolute saints and amazing. But physical community is important, and it's a really important part of our health and well-being. So actually, one of the things that we should be doing in our happy future world, where we've shifted care to much more to the left of the care continuum, would be like let's group exercise, for example. Now, it's very commonplace for anyone that's visited some of the countries in Asia and Southeast Asia, like China and Taiwan, etc., to see big groups of people doing exercise together in the morning, Tai Chi or whatever, some other kind of morning stretches and things like that. Very normal part of their kind of commonplace to see. Not normal here at all in our kind of approach to things, but those types of small, actually, we're kind of leaning towards stuff like that now, more of the social prescribing that we're seeing take a bit more of a hold. But understanding that benefit of doing a group exercise, for example, is not just the physical, you doing some exercise that's going to keep your body healthy. It's the fact that you're taking part in a physical experience with other people and having that physical sense of community. Maybe it's dancing, maybe it's, ballroom dance, or salsa or something where you're actually physically holding on to someone. And that shouldn't be sort of, and you're right, it's a difficult area. People don't like to touch on that because you don't want to say the wrong thing and you don't want to say anything inappropriate. But it's ludicrous to think that people don't need to have some kind of physical contact. And we've got lots of people that don't, that live alone. And that is something that needs to be factored into how do we understand health and well-being, because community and interaction is a huge part of that.
Absolutely. And no, I salute you for addressing that and not shying away from that. And because as you were speaking, even me, I was starting to tense up. I was starting to sweat. I was thinking, how deep does this rabbit hole go? I hope Francesca doesn't really go too deep, but it's important as population health experts, transformational leads, care professionals start to reimagine these what-if scenarios. Because, staying in that dragon's pit where these are uncomfortable conversations, can you imagine what it's like for the individual that's inflicted with these things?
Yeah, exactly.
Where we're uncomfortable and, we're in the confines of our own environment, but we're sweating. It's almost like, like when I was growing up, when we watched, say, Dallas. Now I'm showing my age. Dallas or Falcon Crest or whatever it was. Dallas.
Dallas and Dynasty.
That's another one. Dynasty was the one. Dynasty was more saucy. So what would happen was I used to find myself, if that came on and my dad and mum were in the lounge and everything else, I'll find myself apologizing. I'll find myself saying, sorry, dad and mum, and I'll reach for control because no. All of these things when we're talking about health are so, so, so important that we bring the right people into play, because if we don't, we're going to miss our target. We're going to miss our target. So I understand
is often an issue in this. Yeah. So I'll give you a good example.
Go ahead.
I was working, this is a long time ago now, and it was one of the early test beds for remote monitoring. And the patient cohort was people living with dementia, but still living independently within their own homes. And we'd kit out the homes with all these monitoring things and whatnot. Anyway, you'd have like a named, relative or carer or whoever that we would contact, or who could also contact us if they had any problems or questions or whatever. And one of the devices that you were kitted out with was a GPS tracker device. And we had a call from, and the people couldn't believe it. We had a call from a woman saying she demanding that we tell her, go on our thing and find out the GPS device and tell her where her husband is. Because he's gone off with another woman.
Oh, no, I'm sorry. Let me take a sip on that.
And when we didn't give that information, obviously, because of data privacy, even though that was very clear, the protocol. But when having a chat with the guy about it afterwards, to let him know that this request had been made, he thought it was hilarious, and then also thought it was hilarious that we probably, as in like the team, the clinical team and colleagues, probably didn't imagine someone of his age with dementia was having as much fun, shall we say, as he was having, juggling two women at once. And it's that thing about stereotypes, isn't it? And bias. And that again, often a problem with clinician bias, not referring maybe people of a certain age onto digitally enabled pathways because they just make assumptions that person of a certain age doesn't have that capability or want to learn or whatever. Yeah. The same way that some of the team made assumptions about this gentleman not being romantically active, shall we say, anymore. And, it just, sometimes it's good to have a reminder that we mustn't make these assumptions about how people live. And we mustn't have judgments either about how people live.
Excellent. Because when we look at re-educating the educators that educate health practitioners, social care practitioners, a lot of, sometimes we get in staff from overseas that have burnt in beliefs, about born out of the environment that they're in, which is fine. But however, you come into a technologically advanced civilization or situation in the UK, so like, how do we offer that ability to make sure people who are onboarded understand the rights of all protected characteristics across the whole spectrum in order to deliver care? Because I've seen it play out very negatively for people where people are not sensitive, not empathic, and they put in their own values, principles, beliefs before that of the patient. So there's something there that needs to be done. I'm very conscious of our time, Francesca. I know it's a Friday. You're there melting away in the background, and I do appreciate your time. So what if, I'm going to leave you with ask you just one more what if. What if government, private sector, and all key stakeholders were in a room? What would you tell them now?
Oh, that's a very open question.
Got the ears of all those key individuals.
The main thing I would say, if we had the private and the government and, as you say, all stakeholders, is that we need to be able to collaborate way better than we are doing at the moment. I don't have the answer for how we do that, but we need to be able to work as an actual NHS. We need to be able to be this unique organisation that manages itself in a way, some ways akin to a business, some ways akin to an academic sort of research-based organisation, and ultimately as the lifesaver of our people. So, but private sector is an interesting one, and I think especially some of the stuff that Wes Streeting said, I think we could see some interesting times ahead. And the lines have become a little bit blurred, haven't they, recently? I think especially that was another outcome of the pandemic, was that I imagine, I haven't seen the numbers, but there was probably a jump in the amount of private healthcare memberships that were taken out, and people wanting to avoid waiting list queues. Is quite normal now to go and have a scan privately because you don't want to wait for the waiting list. Or, I've not had an NHS dentist for years because I can't get one. So for me now, it's normal to just pay to have a private dentist. These things have become quite normalised quite quickly. So rather than kind of have no, I was about to say regional, I'm still stuck in my London hat, but having no kind of public ownership of the direction of travel of the private sector health, I think we definitely want a strategy where we're working in partnership, where we're sharing resources, because we are sharing resources anyway. Let's face it, clinical resources we're sharing, if not sort of physical resources. There needs to be a bit of quid pro quo there, but also we need to be working together to innovate and push things forward. So they should be test beds for stuff as well, as they are, but we should be working together. Like, so we definitely need more collaboration in that space, less kind of politicking around it.
Wow. Francesca, thank you very much. The what if episode of the Mic Drop Club. Thank you very much. You dropped so many mic drops on there. You shall listen back to them in due course. But I just want to say on the behalf of all our listeners, a lot of them are from the health technology space. You know, they've been, pinching me, say, get Francesca on. I said, yeah, one day. And that what if you turned into, what was it? That what if has turned into a done with a big tick. So I'm super, super stoked and super excited at the possibilities of some of the stuff that we put out there into the ether. If somebody has the ears to listen and the power to action, if you bring those things into reality, I think we'll make the world a better place.
Everybody
and that's
ready?
what this is about. So
Atomic Mic Drop. Thank you for listening. Don't forget to check out micdropclub.com and get the show notes and useful links. Subscribe to the podcast. Don't just live life. Make life boom.